So good evening, everybody, and welcome to this episode of MOA Masterclass. For further proceedings, I'll hand it over to our convener, Dr. Abhijit Vaigokar. Over to you, Vaigokar.
Thank you very much, Ashok Sham sir, and welcome everybody to yet another installment of these Sunday brainstorming sessions. And this is the brainchild of our Honorable President, Dr. Shinde sir, and our Secretary, Dr. Narayan Karne, and an MOA initiative. And I'm very proud and privileged and honored to be given the responsibility of convening these sessions, which is an excellent learning opportunity for all of us. This entire endeavor is to have case discussions and generate impromptu thoughts, suggestions, and dialogue between the faculty and the experts so that it facilitates learning rather than having didactic lectures. And as you're all aware, our experts who need no introduction speak from their vast acumen and having spent years in hand surgery. Without further ado, I would like to very quickly introduce our panel of experts and speakers. We have Dr. Pankaj Jindal sir, again, who needs no introduction whatsoever. Jindal sir was the chairman of the hand section of the Indian Orthopaedic Association, a very, very active and a very well-read and very experienced hand surgeon from Pune. Welcome, Jindal sir. He'll be moderating the session today. We have Dr. Anil Bhatia sir, again from Pune, a very senior hand and brachial plexus surgeon, and his immense experience will be very invaluable for us in guiding this discussion today. Dr. Jindal sir, Dr. Bhatia sir, welcome to the event. We have Dr. Pankaj Ahire, a very dear friend from Mumbai, and he practices in Godrej Hospital. Again, has a vast experience of more than 20 years behind him, and does the entire gamut of hand and upper limb surgery. He currently serves as the secretary of the Indian Society for Surgery of the Hand. Welcome, Pankaj. It's a privilege to have you with us. We have Dr. Hemant Patankar, who is again a very senior hand surgeon based out of Mumbai, and is known for his out-of-the-box thinking, his very common sense thinking, something that is very helpful for each and every one of us. He has tips and tricks that really leave you wondering, why did I not think of it earlier on? And I've always enjoyed listening to his talks and his vast acumen. And he has published quite a bit. But Patankar sir, welcome, and thank you very much for being a part of this event. We have present, unfortunately, Dr. Vidisha Kulkarni and Dr. Warrior sir could not join us today due to some reasons, and we shall miss their guidance. Those who will be presenting today will be I see Dr. Vidisha Kulkarni in the panel, I'm sorry. So, but I don't think she'll be presenting anything today, but Vidisha Kulkarni, madam, welcome. Dr. Samrat Tauri will be presenting from Nagpur. He is a lone ranger hand surgeon in Nagpur, as I call him. He is the first dedicated hand surgeon in Nagpur. We have Dr. Damodar sir, a senior orthopedic surgeon from Kolhapur, who will be sharing his cases today. Welcome, Damodar sir. We have Dr. Ashok Ghorke from Navi Mumbai, and he is an upcoming hand and upper limb surgeon, has a very deep interest. I see him very often at hand courses, and I really want to thank these people who volunteered and came forward to share their with us. We have Dr. Varade from Nasik, again, a very dear friend and an accomplished hand surgeon. So welcome all presenters to the webinar. And I now request our Honorable President, Dr. Ajit Shinde, to address the meeting before we start the scientific proceedings. Thank you very much.
Good evening, dear friends. I, Dr. Ajit Shinde, President of Maharashtra Orthopaedic Association, welcome you all to our own MOA Masterclass webinar series. This month, we are undertaking the session on hand surgery, and today's topic is fractures of hand. For this Sunday evening, we have none other than Dr. Pankaj Jindal, who is moderating the session, and our EC member, Dr. Abhijit Vayegaonkar, is the convener for today's program. We are fortunate to have eminent expert panelists in this field, starting from Pankaj Ahire and Dr. Hemant Patankar from Mumbai and Dr. Anil Bhatia from Pune. Among case presenters, Dr. Shirish Damodare, Dr. Pankaj Ahire, Dr. Ashok Ghodke, Dr. Amit Varade, and Dr. Samrat Tauri will be presenting different case scenarios and surgical techniques pertaining to the vast topic of hand fractures. Hand surgeries are one of the most delicate surgeries in the field of orthopedics. Contrary to the body is received in general in our medical field. So one must be aware of all the minute anatomical details to give best possible results for the patients. Many a times I have seen that these hand injuries are neglected, especially so in remote region of our country, and such a cases finally present with late terrible sequelae of injuries which are often challenging to manage for general orthopedic surgeon practicing at periphery. Also, acute hand trauma cases, without knowing exact nature of injury, it becomes very difficult to formulate definite plan of surgery. So to tackle all these issues, let's now focus all our attention in careful listening to the indispensable wisdom that our experts have gained over the years managing such injuries. Thus, without wasting more time, I urge Dr. Abhijit and Dr. Pankaj to begin the session. Thank you, everyone. Jai Maharashtra, Jai MOA.
Thank you very much, Shinde sir, for addressing and encouraging us with these webinars. I really appreciate it a lot. Dr. Jindal sir, I hand over the proceedings to you for this webinar. Thank you.
Thank you, Abhijit. We'll start with Dr. Pankaj Ahire. He is going to make his first presentation, and we'll start from Pankaj. Pankaj, please.
Good evening, everyone. I hope I am audible and my screen is visible to all of you.
Yes.
Yeah. So I'll be talking on a couple of different scenarios in PIP joint dorsal dislocation, which is perhaps one of the commonest as well as the most challenging injuries in the hand. One which, if treated adequately, gives excellent results. However, if neglected, leads to a very stiff and a deformed finger. So scenario number one, this is one of the commonest presentations that we'll have. This was a cricket ball injury, 2 weeks post-trauma. I would like to hear from the rest of my panelists what would be the commonest approach by them for this. And of course, in next couple of slides, I would show what I did. These are typically untreated injuries, treated as a sprain on the field, and x-rays may not even be taken on day one. So the earliest x-rays usually we may have are about a couple of weeks later. Dr. Jindal, over to you for putting it to the panelists, if you can. Would any of the panelists
sorry, this was
like to comment?
But yeah, this is open to all three of us. Can you mention what you would do? 2 weeks old cricket ball injury, Pankaj?
Yes, this is a cricket ball injury. Yeah.
Cricket ball injury.
Thank you, Dr. Jindal. The priority, of course, is to get the alignment, the actual alignment of the skeleton, without which finger flexion is not possible at all. Secondly, such a dorsal displacement with comminuted fracture of the volar lip of the middle phalanx would not be possible without some injury to the collateral ligaments as well, because it appears that the middle phalanx is displaced in one side. So an attempt at close reduction under local anesthetic and an evaluation of the stability after reduction would be imperative. We all know that the dorsal margin of the dorsal cortex of the middle phalanx must be aligned with the dorsal cortex of the proximal phalanx for us to accept, for us to know that the joint is reduced. It is only then we will be able to realize how much portion of the base of the middle phalanx is comminuted and whether this joint can stay stable at around 30 degrees of flexion. And if it doesn't, then some sort of form of surgery is essential in order to achieve and maintain the reduction and to retain the restored finger flexion. The various techniques, I'm sure Dr. Ahire will be speaking on as we go along. But the primary step would be to try and get at least a manipulative reduction of the joint first.
So when you say first some site of surgery, what was the first thing that will be in your mind?
No, I don't want to. I don't want to steal Dr. Pankaj Ahire's thunder. In the current scene of the state of the art, I have no doubt a hemihamate replacement would be a pretty high up in our list of choices these days. But let us go on with that discussion. The first thing is that for us to realize that unless the joint is reduced, finger flexion is not possible.
Yes, I think. Yes, yeah. Sorry, sir.
No, we'll go to Hemant also because then you'll tell us what you did ultimately. No, so we'll be the last one. Now, before I go to Hemant, just for the audience, Dr. Bhatia, will you consider various options that we have with us, which of course Pankaj will be talking to us. When you talk of hemi-hemat and which you said will be higher up, would you consider how much is the involvement of the articular surface before we consider hemi-hemat?
That is precisely my point. Unless we get the joint aligned, I would not be in a position to comment on how much of the base of the middle phalanx is comminuted and whether the joint will stay stable at 30 degrees of flexion.
Okay.
I have my doubts, but till a reduction is achieved, we cannot predict. It is 2 weeks post injury. A reduction is going to be difficult.
Yes. So looking at whatever the articular surface is visible, this is not possible to know whether it will be stable or not, right?
Absolutely.
Yes. Hemant, over to you. What would be your choice 2 weeks post cricket ball injury?
Actually, the thing which is discomforting, or I'm not comfortable with this, some dorsal bone piece is there. I would like to know from where it has come. If it has come from the volar side, then probably it will be a hindrance to the close reduction. But as Anil says, I definitely go for a close reduction, at least an attempt at close reduction under local anesthesia. If it is not possible, I'll put a pin in the middle phalanx here and just pull it. I will get the close reduction. The thing, if this is not comfortable, this small dorsal piece which is there, if that is not comfortable to me, the thing which is of great comfort to me is that I can see the concavity of the base of the middle phalanx. And that tells me that this case, if this piece does not give me trouble, or if it does not cause any impingement, I'll get a close reduction in this case, and he will get a good result without any sort of surgery in this case.
Any trick you want to tell us to get the reduction 2 weeks post injury?
Sustained traction for 10 minutes under local anesthesia.
Okay, sustained manual traction?
Manual traction. manual traction. You'll get it. If I by the time Pankaj presents his case or whatever he has done, I will retrieve my case from PowerPoint and I'll present it on the screen. I've done a similar case, probably worse than this, and with a close reduction, and I've got a 6 months post-op. And he's the pianist in a church.
So sustained manual traction without any finger traps or fixator.
Nothing, only hand traction after a heavy breakfast.
Okay, fine. So having achieved a close reduction, any thought
how you would keep it in how you traction for 2 weeks in about 70 to 90 degrees flexion. 30 degrees flexion is too inadequate. I am not scared about PIP joint contractures because I have got my own. I have got a whole set of splints which you know Pankaj very well, both Pankaj, I mean, and the splints which we can correct the flexion contracture. In fact, the secret of this case is to maintain it in flexion contracture. If the flexion contracture is achieved, then the volar plate will heal and it will prevent the joint from dislocating further.
So you will keep it immobilized for how much degree of flexion you said? How much flexion you said?
70 to 90 degrees. Because that is the only thing that will give you stability.
Fine. And any external aid you will use for?
Yeah, I will use a Dynaplast or a nice sticking plaster on the finger. I will not use any external fixator or anything. If external fixator will be required only if I cannot get a close reduction, then I'll put external fixator and pull it out and I'll get a close reduction in this case. I will not, in this case, after 2 weeks, I'll never think of hemihamate, volar plate or any sort of fixation. This is not a very difficult case. Only problem is this dorsal piece.
Yes.
That may alter the situation slightly.
Fine. So as I understand from Hemant, the dorsal piece is a consideration. We do not know where it has come from.
I think it has come from the one of the lateral sides here, because the cortex is intact on one side. I cannot use a pointer here. So this cortex is here on the normal on this side the cortex is normal. This side it may have come from here.
Okay. So sustained traction will be able to get a reduction, then maintain in flexion, and you don't need any internal fixation or maintenance.
I will present by the time Pankaj presents.
Hemant, I got it. Hemant, I got it. Pankaj Aire, please go ahead. How you managed it, please.
Yeah. So I thought this was an avulsion from the dorsal tendon, the dorsal lip, and I thought I would go ahead, fix the volar fragments first, and then open it dorsally. I put an anchor dorsally and reattach it. That was my plan. At 2 weeks, I would always consider stable internal fixation. I have very low threshold for internal fixation. I've seen Dr. Patankar's cases over his work over last few decades that he presents, and he produces wonderful results without actually doing an open reduction. I think that's another way of treating this. There are different ways of treating these injuries. My method would be always attempt a good internal fixation, open reduction and internal fixation. This is what I did. I put as many screws as required, and some of these screws going from medial to lateral actually would fix those fragments which are carrying a collateral ligament with them. You don't require a solid interfragmentary fixation for these fragments. You just need the bony flakes which are carrying the soft tissue attachments with them to be held with the parent bone. A couple of other things, don't hesitate to put a bicortical hold like this. There is no gliding tissue here at all. And the piece which was lying dorsally here, once I finished this fixation, I placed an incision dorsally in the midline so that I could pull the tendon and put it back. It actually was a contained piece from the articular cartilage. So I simply excised it. And this was the movement that I got. I think this is about 3 months down the line. That is the movement in the ring finger.
Yeah. Okay, you want to tell us more about how you achieved reduction, because that was a consideration. Traction, no traction, external fixator, whatever. So how did you get the reduction?
So it is always an open reduction straight away. I do not attempt any closed reduction, especially when these present at 2 weeks plus. All those who are little new to this area, multiple attempts at closed reductions can cause more damage than the original fracture. So as Dr. Patankar said, your attempt at closed reduction has to be in the form of sustained traction and minimal manipulation. There cannot be multiple forceful manipulations, because the disaster in these fractures is to have a damage to the intact dorsal lip. If that lip fractures, then you have converted a volar lip fracture with a dislocation into a pylon type of fracture with both lips fractured. So we definitely don't want any forceful reduction. So exactly how I did it. So I'll just show you in this case, almost an identical looking case. This was the piece which had gone dorsally in the earlier case, this piece. And again, this also presented around 2 weeks post-operatively. And this is exactly how I did volar Brunner incision. This structure is the volar plate. These are the flexor tendons which are retracted. This is the volar lip fragment which is retracted. And this is the articular piece which will be brought down. And once that is done, then again, this went on to have a good internal fixation. Again, as many screws as required to get the pieces in place. Do not hesitate to put bicortical screws. And once you achieve a good reduction, okay, if the joint is reduced, a few steps or defects in the articular cartilage are quite well tolerated. What is not tolerated well is subluxation of the joint. So this patient again and once you have a very stable fixation, you can mobilize them early. And as Dr. Patankar said, flexion deformity is not something which you should worry about. Flexion aids stability in these joints. Whatever flexion deformity you may have as a residual deformity at the end of 6 weeks, even at the end of 12 weeks, can be effectively stretched out by multiple ways, right? From passive stretching to splints, which will stretch it out. That is seldom a problem. And to accept a finger which is PIP joint, which carries a deformity of about 10 degrees of flexion, is very commensurate with good function. So really it doesn't hinder any function. So if we are not as lucky to get patients early enough for fixation or a fracture which is as comminuted as this, the focus still has to be on the reduction of the joint and trying to create a volar restraint. I think in the discussion that just took place, if the volar tissues heal well, the joint renders itself stable. So the focus here was again to reduce the joint well, put the pieces together. This was the one which I started off with screw fixation, but I realized that I will not get a very good screw fixation. So I simply put a few. I put 2 sets of pull-out sutures, and they're tied over a button. And this again would go on to heal. Once I have a congruous joint, I'm really not worried about this flexion deformity. I would stretch it out. There are a few joints which are non-reconstructible, more than 50% of the joint gone. This is more than 3 months post-injury. 3 months is my upper threshold for attempting any open reduction. I would attempt open reduction up to 3 months, but I think beyond 3 months, I would consider salvage. And these are the areas where this PIP lip is now completely non-reconstructible. So one such patient, this was again about 3 months, a big defect, a tiny piece which is attached here with a subluxated joint. This is what I did for this patient. This was my method of salvage. So what I did here was, of course, try and get a joint which is congruous. Once I removed this dorsal blocking wire, there was still some residual subluxation. You can see a button here. So obviously something has been put in this defect which is being pulled out here. So I'll just explain what this was. This was actually a volar plate arthroplasty. The other option in such patients would be a hemihamate osteochondral graft. So what exactly is a volar plate arthroplasty? Volar plate arthroplasty is filling the volar lip defect using the volar plate. So this is, if you can correlate this X-ray picture with this line diagram, I'll just go back, this X-ray picture with this line diagram, you will realize that this is that non-reconstructible volar lip. This is the subluxated joint. This is the defect that we are talking about. And the volar capsule, which is thickened at this region where it attaches to the volar lip, is what we call the volar plate. So again, so this is the volar plate. This is your non-reconstructible crumble of bone. This is where it would normally belong, but unfortunately it cannot be in this case because it was crumpled. So we simply remove and throw it away. And now we have a volar plate with its free edge, joint which is reduced and held with a temporary wire. What you do is, this volar plate is now inserted into that defect. Two sutures are passed through the volar defect, and then they are brought out onto the bone and tied over the skin over here. This is good if there is about 50% bone loss and there is a genuine problem of recurrence of subluxation as the soft tissue stretches. So this is what was done for this patient. And this patient, this is the right side index finger which was operated, went on to heal very well with excellent range of motion. He also had an old Malay injury in the index DIP joint, which he wanted not to be treated. This was an old injury, older than current injury. Occasionally you have a defect which is much bigger than 50%, and this was 5.5 months post trauma. I distracted, and this fragment would distract with the joint. So I subjected this patient to what is called as a hemihamate arthroplasty. This is called as a shotgun approach. This is again a Brunner's incision where the volar aspect of the joint is open like a shotgun. This is the head of the proximal phalanx. This is the base of the proximal phalanx. This is the dorsal rim, and this is the volar rim, which is completely fractured and is not amenable to reconstruction. So what was done is that those pieces of bone which cannot be reconstructed have been removed. The defect has been converted into a nice rectangular defect. A matching osteochondral bone graft is taken from the hamate and placed in that defect. So this is the bone piece which is taken from the hamate. This bone piece. This is your original parent bone dorsal lip. And 1, 2, 3 screws used to fix it. And once this is fixed, that is the defect that is created. That is the hemihamate osteochondral bone graft that is taken and restraint nicely created. This is on table patient, has a very stable joint and almost more than 90 degrees of active flexion because this is done. So to summarize, you have a pure dislocation, dorsal dislocation. It is a volar plate injury, which we have not discussed today. If you have a stable fracture pattern, a close reduction works. That stable fracture pattern is what Dr. Bhatia was talking about, where once you reduce the dislocation, it remains stable within 30 degrees of flexion. You do not require any more amount of flexion to keep the joint reduced. That is classified as the stable fracture pattern. Another way of classifying this as a stable fracture pattern is less than 40 degrees of 40% of articular involvement. If you have an unstable fracture pattern, you need to fix the cases which I discussed with you. These are the cases where more than 30 degrees of flexion will be required to maintain joint flexion. Dr. Patankar has another view at it. He does not mind more flexion. That's another view of looking at another way of looking at these. These are also the fractures in which more than 40% of articular fragment is involved. When you have neglected, typically my definition of neglected would be more than 3 months. If you have less than 50% involvement, you could do volar plate arthroplasty. If you have more than 50% involvement, and if there is less than 50, but you do not want to do a VPA, hemihamate is perhaps a gold standard today for this type of injuries. Thank you very much.
Dr. Bhatia, you want to say something because you were the first speaker as a panelist. You want to add something here?
I don't want to add something. I just want to act as the devil's advocate. Dr. Ahire, would you at any stage,
Yes.
I know the answer, you know that I know the answer, but for the audience who are a bit uninitiated in hand surgery, would you at any stage consider a transfixing K-wire to hold your reduction after you have done a manipulative reduction?
If you require a transfixing K-wire to hold the reduction, I would reckon there is something wrong. There is either there is a maybe an interposition of the soft tissue, which is rare in the PIP joint, or you are trying to forcibly hold an unstable, inherently unstable joint into reduction by a K-wire, which would eventually subluxate once the K-wire comes out.
And would you also elaborate on the pitfalls of putting a transfixing K-wire in an articular surface which is only 7 millimeters anteroposterior and about 8 or 9 millimeters medial to lateral?
Yeah, I would just coming to that. So ultimately, even if you put a transfixing K-wire, the joint will continue to remain stable and mobile only if the volar restraint, the volar plate or the volar leaf fracture has healed well. Having said that, if you are forced to put a K-wire, my suggestions are use a very thin K-wire, 1 mm, with a proper drill and a single attempt. I do put K-wires across a PIP joint when I am correcting the swan neck deformity. So to say that I do not put wires across the joint, I would be lying. However, for a fracture dislocation, which inherently requires restoration of the volar restraint, bony or soft tissue, depending on K-wire for stability is something which I would not advocate.
Thank you.
Okay. Hemant, you want to add something before we go to the next one?
No, just for the audience, for the, I would say, for the other surgeons who are interested in hand surgery, I would like to ask Pankaj to just elaborate his choice of when you take a Brunner's or when you take this incision, Brunner's incision for opening the joint. Is there any choice depending on the X-ray where you would like to take the angle of the incision, either on the medial side of the finger or lateral side? Does it matter? And is it dictated by the X-ray, AP X-ray? Because you will see in the first slide which you showed, your bone was comminuted on one side, which you pointed out to me with your pointer. So the incision is dictated by that X-ray, or it is you can take it depending on your comfort, surgeon's comfort. And secondly, second question is, why not use 1.3 millimeter screws? They have got a better head than a 1 millimeter screw, because they give you a good buttressing effect also.
Yeah. So I will take the first question first about the Brunner's incision. Frankly, I place it according to the comfort that I enjoy on that particular day, sitting where I am sitting with respect to the patient. Because I aim for a complete exposure from collateral to collateral anyways, irrespective. One thing I definitely do is, I was just looking for a pen here so that I could, okay, I'll just show you with this. So earlier I would take a Brunner incision going, like this and triangle like this. Now I would go in the middle of the middle phalanx, go in the mid-lateral line, and then from the middle of the proximal phalanx. So I virtually have a nice long incision here. So I'm not struggling in one corner of the incision anytime. And the flap I raise is right up to the neurovascular on this side, taking the neurovascular with that flap. So I'm at no point I'm making any attempt to operate through a very small window. So I would not be really concerned about the fracture anatomy where I am placing the angle. However, for the little finger, I will try not to place that angle on the ulnar border. I would try to place it on the radial border. And for index finger, I will try not to place it on the radial border. I will try to place it on the ulnar border. Beyond that, I will not have any, I will not be very choosy about where to place that angle.
Second what question, is in your mind? Sorry. Pankaj, please. What was in your mind when you asked that question?
Yeah, the reason is that I feel that, no, he has elaborated it very nicely. But what I feel is that depending on the AP X-ray, if the fracture fragment is more on the medial side, then it might be more wiser to take the incision, the apex of the incision on the medial side, so that you have to retract the flap slightly lesser, because your screws are not going to be directly AP for fixation. For hemi-hamate arthroplasty, it doesn't matter because the bone is anyway out. You're going to put the screws in the AP direction. Suppose, yeah, 1 minute. Suppose your fracture is at an oblique angle, then you're going to put the screws from medial, volar medial side to dorsal lateral side. So that might be easier if your flap is on one side. That is my, yeah.
Yes, so whenever I have opened these fractures and quite a few of them, so I've never found a very predictable fracture pattern in that volar leaf, first of all. So the pieces are all over. So there are screws which are bang anteroposterior. There are screws which are at 45 degrees. There are screws which are coming virtually in the coronal plane, depending on the where the fracture fragments are. But I fail to see a pattern which will let me decide preoperatively where to place. And in any case, as I said, I aim for a very broad exposure of the entire articular surface, so we do not miss out anything.
Accepted.
Yeah. So your second question about
1.3 screws.
1.3 screws, and okay. I use 0.8 millimeter wires to hold these fragments. If at all I have to hold this fragment before putting the screws. 0.8 millimeter K wire itself can be used as a drill for putting 1 millimeter screws.
Agreed.
And should my 1 millimeter screw not hold, not work, these are very flimsy fragments, I still have an option of discarding that 1 millimeter screw and putting a 1.3 millimeter screw. There are occasions in which I have started with a 1 millimeter screw and discarded and put a 1.3 millimeter screw. The only problem against 1.3 is many of, as you would have seen, I have put 4 screws here. These are virtually 4 screws in 4 different fragments in that tiny area. I'm not sure each of those individual bone fragments is ready to take a 1.3 millimeter screw. That's the problem.
Fine.
In a hemi-hamate, I would not hesitate putting all 3 1.3 also, because it's a large chunk.
Agreed.
Okay.
It is only for the.
Sorry, Hemant, please.
Yeah.
Go ahead. Hemant, go ahead.
No, it was only the question was asked to Pankaj only to elaborate and make it more clear to the audience.
Yes.
Okay, Pankaj, one question.
Yes, sir.
Since you are putting so many screws there, any situation you have faced where you had gone in with the plan of putting in screws and then you abandoned it and opted for something else because the screws just would not hold anything?
Yeah, in fact, the third case which I showed, which was massive comminution, I went in with the idea of a screw. The exposure was for the screw. I attempted putting a screw, and I realized the screws were just walking through bag of bones. That time, I just put everything. I just put a suture through the volar plate with the bone pieces in it, and put a pull-out suture on the dorsum with a button on the dorsum. That was the plan B, and it worked.
Okay.
Would you like to use a buttress plate in those circumstances? Small buttress plate, which has been described by the Singaporeans.
Yes, I have used a buttress plate as well. It requires some sacrifice of the A4 pulley
Yes.
to get the stems there. And if there is any other way of achieving this, I would. If it is only a volar lip fracture, and if I am quite if I'm quite decided that I'm going to only fix that fragment, then only I would consider a plate. Any fracture which is extending more than 4 or 5 millimeters into the middle phalanx from the articular surface, then I know that my plate has to go maybe around 8 to 10 millimeters ahead. I would be a little hesitant. But yes, that is a definite option. And fortunately, the attachment of the FDS is such that it does give you enough place to put three screws in the plate over there. It is an option which I have not used for comminuted fracture like this, but I have used it for larger fractures where I just needed 1 screw to buttress it.
Okay.
Can I just butt in for a minute?
Yes, sir.
Yes, Anil.
Can you just highlight the fact that one should not embark on this sort of fixation without having the full armamentarium of instruments and the right type of drill? This is certainly not something to be attempted with an electric drill or a high-speed Manman drill, which every orthopedic surgeon would have in his operation theater. It requires a specific synthesis type drill that I know you possess, which is essential in order to make a precise fixation like you have done here.
Yeah, I mean, this point could not have been stressed anymore, sir. Absolutely. Using correct instruments, toning down your movements, toning down your forces to that tiny bone is very important. We cannot have the same play of instruments and same play of our hands as you would do for a radius fixation or a femur fixation. Absolutely agreed. We should not embark on this without the correct implant and the correct instruments. Absolutely agreed.
And you may add probably tourniquet, effective anesthesia, and magnification.
Yes, yes, absolutely.
Okay. I think that's enough. Pankaj, thank you very much for highlighting.
Thank you very much, sir.
Very important topic for a cricket-loving country here. We go on to the next speaker now because I know even 1 extra hour will be inadequate.
We managed to lose today's match.
Okay, so we go on to the next one. Who wants to? Shirish Damodare. Shirish, please, over to you, Shirish.
Yes, yes. Just a minute. Can I hear you? Can you hear me?
Yes, Shirish.
Yeah, this is the same fracture which we are going further. This is on 25 years of male with a cricket ball of injury, left middle finger PIP joint. Now this is a single major piece which is less than 50% of the articular surface. So
Shirish,
these are the various different options which have been discussed.
Shirish, delay in presentation. How old is the injury?
No, this is a fresh injury.
Okay, fine.
Yeah. So we have some different technique of fixations. We reduce the fracture in an extension and we force it anteriorly. We reduce the fracture. Then we pass an K-wire with an T-handle from the proximal surface to the posterior surface. Then we cut the K-wire and pull it out. And again fix it with a transfix with a transarticular K-wire. This is a major piece, we could achieve this. And this doesn't entangle any tendons because we pull it out and this is a bare area. So both the K-wires go through the dorsal surface to a bare area of the tendon. And here the K-wire is withdrawn. So it doesn't entangle any flexor tendons. This is a course of, yeah.
You want to tell us how long you kept those wire A and wire B?
Yeah, both I kept for 6 weeks, but we allowed the movement of the distal interphalangeal joint in that splint. And this is a post-operative follow.
Can you show us the extension? Oh, okay, fine. Fine. Pankaj Ahire. Pankaj, you want to ask any questions here?
Excellent result. Question is whether we are moving away from very well laid out principle of management of intra-articular fractures, which is try and mobilize these fractures as soon as you can. 6 weeks of immobilization with a K-wire is something which I am very uncomfortable with, but the test of the procedure is in the result that you have shown, and congratulations for that. Somehow I am very uncomfortable with the idea of passing a wire which is jutting out a couple of millimeters on the volar side. The technique that you described is wonderful. It's good for a large volar fragment. Not sure whether it will be as applicable if the volar fragments are comminuted, which they often are. But I think for select few cases, this method of fixation of the volar fragment could be applicable. If mobilizing a PIP joint with this wire alone would never be possible because of transfixation of the extensor tendon on the dorsum, it is painful. Transfixing K-wire is something which in the PIP joint for 6 weeks is something which I'm extremely uncomfortable with, despite the good result that you have shown.
If at all you do immobilize, when would you withdraw the wire, transfixing wire?
Myself,
If you do transfix it in a PIP joint, how soon you would withdraw the wire?
In a case of a fracture dislocation,
In this patient,
I would not. I would not.
Okay, Hemant. Okay, Dr. Bhatia.
I agree with Pankaj Ahire that I would be extremely skeptical about putting a transfixing K-wire when the only remaining articular surface of the base of the middle phalanx is so small. To try and put an oblique transfixing K-wire would damage that further. So I would restrict myself to methods which would maintain the reduction consistently for 3 weeks without anything going across the joint. If an external means is not possible, I would go for an internal fixation like he has shown. Although my experience with these mini screws is very, very minimal. I don't do much of this work currently, but certainly it would be my wish to get more experience with that.
Shirish, can you show your X-ray again, please?
Yeah, just a minute. Post-operative or pre-op?
Post-operative. Okay, while you come, fine.
We have done total 4 cases.
Yeah, good.
With a similar results.
Yes. The most important thing that is important for everybody to know is we have to restore the articular congruity, like has been shown in the earlier talk on the similar thing by Dr. Hire also. You have to restore it. We have options as Dr. Hire has mentioned about hemi-hemid, about volar plate, about then Hemant has shown beautifully about his experience of conservatively managing, but bottom line in all 3 is you have to immobilize in flexion here in varying degree. Books may say 30 to 40 degree, but Hemant is extremely comfortable in immobilizing much more degree of flexion of 70 to 90 degree. But if at all you do immobilize in 70 to 90 degrees, you be extremely vigilant and have a backing up of a dynamic splinting so that you can correct it, and do not rely on physiotherapists who will put your hand in wax bath and say this is a surgeon's fault. Am I wrong, Dr. Hire?
No, not at all.
So most important thing is you have to have a backing of good splinting to correct any residual flexion contract. And residual here means 70 to 80 degrees, a big flexion posture. Hemant, one more X-ray you have?
Yeah, I have one more X-ray post-op.
Before that.
Before that.
Yes.
Oh, intraoperative. This.
Yeah, go ahead. One more. Yeah, good. Okay, I see your wire on the front is blunted out. So you pass your wire from volar aspect or dorsal aspect?
Volar aspect.
Achha, so and this was close means?
Yeah, close means.
So your wire went through the flexor tendon, you withdrew it more dorsally, is that right?
Yeah, through the flexor tendon, we cut the wire and withdraw from the dorsal aspect.
I'm curious. So maybe, as I understand from the panelists, if at all you do put a wire, transfixing it, try removing it early. Am I right, Dr.?
Yeah.
Or if at all you can, if you get a reduction, maintain it in flexion with a splint, as Dr. Patankar was mentioning, but K-wire across probably is avoidable. Am I correct, Hemant?
Yeah. How late can this method be attempted?
Now we are done in all the fresh cases.
Fresh
We are
cases.
not done in the old cases.
But by the same token, in the fresh cases, it doesn't require anything. You just require to maintain it in flexion. The joints are quite good.
I do agree, but he was requiring more flexion, so we fixed it.
Hemant, what probably Hemant
More
is
than
saying
30 degrees.
Shirish,
Yeah.
what Hemant is saying is next time you do the same thing, but you can avoid putting the transfixing wire. Am I right, Hemant?
Yeah, yeah.
And instead of
Avoid
transfixing
putting any wire.
immobilize with a splint in about 20-30 degree of flexion, you will
Yeah.
still be able to maintain the congruity in a similar fracture pattern.
Okay.
Is that right, Hemant?
Yes, absolutely.
Pankaj Ahire, you want to say anything?
Yeah, I'm just staring at this X-ray. Yeah, sorry, it went away. So ultimately, what is being achieved here is there is a good apposition of the volar lip with the parent bone, and the joint is being held in 30 degrees of flexion. That is all these wires are doing, and they're doing it pretty well. This could be one way of doing it, but perhaps there could be less harmful and more predictable ways of doing it. Like instead of putting a transarticular wire, a dorsal blocking wire could do the same job without damaging the articular surface. That this is the only thing that I could see negative in this. Otherwise, it has given the result, and ultimately, if the results are good, we have to accept that this could be one of the methods.
We are practicing in Kolhapur, which is a very smaller city.
No,
It
Shirish,
doesn't have much backup here.
You have done
So
excellent.
in the smaller cities where we have much less ornamentarium, this was the thing which we had done.
That's what I'm maintaining, that you don't require any armamentarium. You require only hands and traction, rubber band.
No, he's saving your money more. He said you can say half the K-wire more, but not transfixing it. That's what he said. You save further money.
But that needs more training for the splintage, post-operative rehabilitation.
Yes.
This is a second case similar, a 15-year one. Then this is a result.
Wow, that's nice.
Yeah, bottom line is you have to restore the articular congruity.
Yeah.
As I understand from two presentations, one from Dr. Ahire and one from Shirish again, they have not immobilized the joint in an external fixator spanning across the joint. And both have mobilized, both have restored congruity, most important thing. So if at least I can say, I'm sure Hemant must also be seeing and Pankaj Ahire must also be seeing external fixators being put with a joint not reduced. So maybe a last question to Dr. Ahire before we be on, keeping the time in mind. Dr. Ahire, how often you see a fracture dislocation not reduced and put a fixator?
So the commonest problem that I do see with this is joint not reduced and every possible other treatment done, including a transarticular K-wire, including a interfragmentary K-wire, external fixator, all sorts of treatments, but the bottom line of reduction of the joint not being done. And the way I see it is because it is such a simple method, it gets overlooked. You know, the way Dr. Patankar said, all you need to do is put the finger in flexion once the reduction has been achieved, and there is very little that is required after that. So yes, I do see this very, very often.
Can I ask something, sir?
Is Dr. Jindal's connection stuck? It looks like. Yeah, go ahead.
Yeah.
Go ahead, Samrat.
My query is that instead of putting a wire from volar to dorsal, if we get a reduction, the same thing can be done from dorsal to volar. It doesn't displace more volarly. The same fracture with such a big volar fragment there, we can fix it from the dorsal to volar. We can put a K wire.
Yeah.
But it causes a little bit of more displacement anteriorly.
So we are holding it on the volar side. It's a small fragment, just compressing it and.
But we can't hold with the
What are the
fingers
thoughts of
alone.
other seniors?
Okay, aa gaya वापस.
It is difficult to hold with the fingers.
I lost control because there was a power failure for that whatever moments here. Okay, I'm sorry, Shirish, I missed last 60 seconds.
So Dr. Tauri's question to Dr. Shirish was that instead of putting the wire from molar to dorsal across the fracture, could it have been easier doing it from dorsal to molar? And Dr. Shirish was just had begun to answer that question.
Okay, sure.
Yes,
Thanks.
Dr. Shirish.
The principle for any fracture fixations, even for the ankles also, nowadays we go from the smaller fragment to a bigger fragment. But when we pass from dorsal to ventral surface, many times the fragment get displaced and it gets more comminuted with the multiple passage of K wires. So we started doing this and probably it has helped us, though in smaller cases, only 4 cases we have done. But somehow that helped us. In a single shot, we could fix it and it adequately compresses the metaphyseal bone, which is a cancerous bone.
Okay, fine.
Thank you, sir.
Thank you, Shirish. I think we'll go on to the next one. Amit, please. Amit, Dr. Amit Varade.
Yeah.
Okay. Samrat.
Yeah.
The next one.
Sir, shall I present?
Yes, you are live. Go ahead.
Sir, can you see the screen?
Yes.
So this 55-year-old gentleman, one day after the injury, and he presented with pain and swelling at base of the right thumb, and he had restricted movements at the CMC joint. And on examination, his thumb was a bit short than the other normal thumb. So this is his X-ray. So may I ask the analyst, is there any specific X-ray views to see this fracture and how to reduce this fracture, and what is the diagnosis and how to reduce this fracture and dislocation of the thumb?
Okay, Dr. Bhatia, please.
Kaponji has described specific PA and lateral views for the base of the first metacarpal, which are very important because the exact alignment at the carpometacarpal junction of the thumb can only be judged in those views. A routine PA and oblique of the hand does not give us the right imagery for the thumb, because the thumb is at a different in a different plane as compared to the remaining metacarpals. So the Kaponji view, if anybody is interested, the book Christoph Oberle and I had published in 2000, Manual of Upper Limb Surgery, the Kaponji views are described in detail in that, and also in Tubiana's book. But the essential point being that the surgeon has to accompany the patient and hold that particular position so that a proper PA and lateral view of the base of the thumb can be taken.
Okay,
there are
fine.
specific criteria which will be very difficult for me to illustrate just by talking. I mean, there are specific criteria to know what is a good PA view of the base of the thumb and what is a good lateral view of the PA of the base of the thumb.
Fine. Dr. Patnagar, you want to take over those questions, please? If Hemant is not responding, Dr. Ahire?
Unmute yourself.
For this particular case, I think all the information that you need for treating this fracture is very evident. But yes, there are views described for the thumb, which I, if I may show you, if this is the plane in which you are going to take an X-ray with the views rays coming from top, that this is going to give you a lateral view of the thumb. And in order to get the AP view of the thumb, you will need to hyperpronate the forearm, and now the thumb comes to lie in this plane with the nail plate touching the surface of the X-ray plate. This is going to give you the correct AP view of the thumb. But as I said, in this particular case, whatever you need to see is very evident. There is a subluxation of the first metacarpal joint, CMC joint, and there is a large volar ulnar fragment, which is very typical of a Bennett's fracture. So we really don't need any more imaging for this.
Okay.
Hemant is back? No. Okay. No. Hemant, yeah, please.
Yeah, as Pankaj and Anil have said, that if the diagnosis is quite obvious, but it's a very unstable injury because of the pull of the adductor and abductor muscles. So it will require close reduction and fixation. Various methods of fixation have been described and can be used. And I think I'll leave it to Amit to describe his way of treatment.
Amit, you want to tell me what is the difference between Bennett fracture and Rolando? Because I know the audience would be interested.
Yeah, yes, sir. Please, sir, we want to initiate the discussion, and this will be a good opportunity. Sir, you.
Go ahead. Amit, please go ahead.
So, at the base of the thumb, this is whenever there is a big ulnar side fragment and dislocation, then we label it as a Bennett's fracture. And when there is a intra-articular comminution at the base of the thumb, then we label it as a Rolando's fracture.
So you mean when there are 1 + 1, this is Bennett, this
is Bennett's fracture.
Parent metacarpal plus fragment is Bennett. Metacarpal plus more than one fragment is Rolando. Is that right?
Whenever there is the intra-articular comminution.
Okay. So more than one. Yeah. Okay.
Yeah, then we label it as a Rolando.
How did you proceed? What did you do?
This, so the how to reduce these fractures, because this is these fractures are very unstable because of the due to pull of the two muscles, APL and adductor pollicis. APL pulls the thumb proximally, dorsally, and in supination. So whenever we want to reduce these fractures, we have to give traction, and then we have to pronate, and we have to press the base of the thumb, base of the metacarpal, to reduce these fragments. So I have a short video here, Siam video. So first traction was given, then pronation was done, and with the thumb, base of the thumb, base of the metacarpal was pushed, and it was put in its original position. So after the reduction, K-wire was passed from the base of the first metacarpal to the trapezium, not through the fractured fragment, and 2 K-wires were passed from the first to second metacarpal. And this is the 1 year follow-up. So this is united very nicely. And there are the clinical photos.
Yeah, Hemant.
Yeah, it's a very nice way of fixing it, and a very nice result also, where the fracture has been reduced very well. Only point I would like to make out to tell the audience is that whenever we do a fixation like this, I would urge, or at least recommend, that a small incision is taken there and you identify the EPL and EPB tendons, because many a time the wire will go through the tendons and you will have a poor result only because the wire has tethered the tendon while fixing the fracture. We should also pay attention to the tendons when we are fixing the bone. And secondly, this is a 55-year-old gentleman he already has symptoms of CMC joint arthritis. So we should warn him that he's, in spite of the good result or good fixation, he may still complain of pain because of the arthritis, not because of the fixation. And that should be told to the patient that he has got a CMC joint arthritis from the beginning or before the injury also.
Okay.
Hemant, would you consider excision of the trapezium, since you just mentioned about arthritis primarily?
Pardon? No, I let it heal first. Excision of the trapezium, that's a different topic altogether, the treatment of CMC joint arthritis.
No. What I'm saying is, you do this fixation, patient will have persistence of symptoms. He may or may not have had pain before the fracture here, and now he has pain because of the arthritis. Now patient comes back to you, say, doctor, you have not done a good surgery and it's hurting. So what my question is, will you discuss this with the patient? Look, this would be the treatment of the fracture, but in view of the arthritis, this is the treatment I am offering. So that's what my question is.
Yeah, normally for CMC joint arthritis, the best treatment is a trapeziectomy only. That gives you, I would say, assured pain relief to the patient. But that is afterwards. That's not. I would not like to discuss this. I would like to just tell the patient that he's already got a pre-existing CMC joint or lipping of the trapezium, which means that he's already having arthritis.
Fine. Anil, you want to say something here? Dr. Bhatia?
Say that again.
Over to you for your, how would you manage this fracture?
Since the reduction was achieved, I would go for a wire which would engage the fragment. Because such a large fragment, I would not be very keen on transfixing the CMC joint per se. But to add the Isla technique along with it, I think is a bit of an overkill, because to maintain the thumb in abduction by the Isla technique is not everybody's cup of tea. The distal wire almost always has to be passed from the second to the first metacarpal, and not from the first to the second, because it is traversing both the first dorsal interosseous and the adductor. So and engaging the second metacarpal, passing the second wire distal, the second distal wire from the first to the second metacarpal is a very, very difficult trick. Almost inevitably, you will be bringing the metacarpal in the plane of the other metacarpals by putting those K wires. Therefore, maintaining abduction and antipulsion of the thumb is practically impossible with that frame which was shown. I would be quite happy to fix only the fracture and maybe an additional wire into the CMC joint, not the wires across the first wave.
Pankaj, I'm coming to you. Did you have any problem putting your wire between the two metacarpals? Or how many times you have to insert your wires? Tell us honestly.
So in two or three attempts, not more than that. 2 attempts, I can say.
No, good.
I would be very, very, very surprised.
Dr. Hire,
across the joint, you mean you are asking, or from first metacarpal to second metacarpal?
Yes. Did you have any problem in fixing those wires, that you would put multiple? You have to put angles this way or that way to negotiate and engage the two metacarpals?
No, not really, sir.
Not difficult. Okay. Dr. Ahire, please.
I just wanted to ask one question, sir. In which cases you would go for, in which cases of Bennett's fracture, you would go for open reduction?
Amit, we'll hear Dr. Ahire, and then we'll come back to a question to all the panelists.
Yeah, I just have a couple of comments. One, Amit, in your X-ray, I think one of the most important forces for reduction of this fracture is extension at the CMC joint. I see very less extension. The CMC joint must go in complete extension. I would want to ask you, which wire did you pass first, the transfixing wire or the wire which is going from between the first and the second metacarpal?
Transfixing wire.
Transfixing wire first.
Yes.
Okay, then why did you feel the need to put a transarticular wire?
No. Trans-articular wire.
Trans-articular wire first, and then between the
Then
metacarpals.
for additional stability, 2 wires.
Okay. Okay. So
can I butt in again, please?
Yes, sir. Yes, sir. Please go ahead, sir.
The method which of passing the wires from the first to the second metacarpal has been described by Isla to maintain the abducted position of the thumb with so that the reduction of the Bennett fracture is maintained without trying to put a transfixing K wire. Okay, the whole idea was to keep the shaft fragment more distal in traction and anchor it to the second metacarpal. And that is where all the difficulty arose. Since you want to maintain the alignment of a fracture which is at the base of the first metacarpal, you have to have the thumb in opposition or in abduction or in antipulsion. So when you put the thumb in antipulsion, engaging the 2 metacarpals in one go is an extremely difficult trick. So what I see here is that the 2 metacarpals in fact have been brought in the same plane in order to pass the wire from one to the other, and that defeats the whole purpose of putting the transfixing wire in the first place. So I would not recommend combining the 2 techniques. You either do one or the other.
Okay. Okay.
Dr. Ahire, now to your question that Amit asked, when will you do an open reduction?
Should I answer or somebody else?
We'll ask. Come to you, Anil.
Yeah.
See, if a manipulative reduction is not possible, an open reduction is imperative because the joint is doomed to arthritis if a reduction of the main shaft fragment to the trapezium is not achieved.
Dr. Ahire, please.
Yeah, I would do open reduction if I'm not happy with the articular reduction after a closed manipulation, because I have had to revise my closed reductions for this reason in some of the cases. If the articular chunk is more than 50% of the total base of the first metacarpal, as seen in any one of the views, and if I feel I can give a good interfragmentary fixation for that, I would give the choice to the patient that I can fix this with interfragmentary screws, whereby the patient may not require a plaster cast for it and can simply go in a removable splint. That is one option I would definitely give to the patients. For smaller than 50% fragments, I would perhaps not go for any internal fixation, interfragmentary screw fixation.
Hemant? When
Yeah,
will you do
essentially, I agree with Pankaj. That would be my approach also.
Amit, if I can say, though I'm a moderator, my indication for open reduction will be a malunion. You have to do an osteotomy and reduce. So I've done almost quite a few of these malunions. Okay. Anything else, Amit, you want to add, or panelists you want to add?
No, sir. Thank you.
Pankaj, you want to add something?
Yeah, when we do it for the malunion, as you said, many of these fragments are quite tiny. So when we are doing malunion surgery for very tiny fragments, it may be a good idea to actually do the LRTI part of the trapeziectomy surgery to augment, to ensure that the metacarpal does not subluxate. And I have done that with good success in patients for whom I have had to revise my fixation because there was a malunion or because there was a step in the articular step, articular cartilage.
Dr. Jindal, I would like to really know your opinion of the Isla technique, because I have had a lot of difficulty in engaging the 2 metacarpals in one go.
Honestly, I have not done it this way because I'm comfortable passing the wire from the metacarpal into the fragment.
Exactly. No, I mean, what I meant was passing the wire from the first to the second metacarpal is not a very easy trick, according to me.
Yeah, I've not done it. I didn't do it because this worked nicely, putting the wire from the metacarpal into the fragment.
Perfect. Right.
Can I make a point, sir?
Yes, I'm sorry, Abhijit.
Yeah, sir, Professor Mathula once told me it's better to put the wire from the second to the first metacarpal. And
exactly. The Isla technique, the second wire has to be passed from the second to the first and not from the first to the second.
So that it maintains the abduction and it's easier to pass it that way.
Yeah. Yeah, that's precisely my point that I was trying to raise.
Right.
That the Isla technique by nature implies that you have to put the second wire from the second metacarpal to the first.
True.
So that the thumb is kept in abduction.
Right, sir. Yeah.
Sir,
Thank you.
I wanted to ask one question to Dr. Abhijit.
Yes.
Go ahead.
Is the role of arthroscopic reduction and fixation in such kind of fractures?
I feel it's an overkill. I don't think it's a good idea.
From what can I add something? I have not done, of course. I think the past Prime Minister of France had this fracture, and he had a scopy, and then they put in a wire. I think he should have come to India, and Amit could have done the surgery much easier. Yeah, so I mean, one of the fellows was visiting France, and he had the surgery, so he said, "This is what happened." I said, "Well, very good."
So the technical problem is your hand is in a traction, and it's not very easy to give the pronation and to rotate, and it's just an overkill in my humble opinion. So just putting a wire is enough, I guess, for fresh fractures.
So
I know things are being recorded here, but I can add here. I was spending a month with PC Hope, who people say is a pioneer in scopies, and they put in a scope in CMC joint, and after half an hour, say, "Oh, I'm sorry, I am between scaphoid and trapezium." So, sir, I'm happy that I'm showing you, but if I had seen it, I would have gone into depression. Yeah, Pankaj.
Yeah. Just on this point, I think PCO at one particular point also was talking about his criticism, the criticism that he receives for pushing the limits of arthroscopy. He actually very nicely said that he considers it as his moral responsibility to push the limits of arthroscopy in hand and wrist. So that what I do today with number of errors and in 3 hours, a few years down the line, many people will do it with fewer errors and much shorter period of time. I think it's a wonderful investment that he is doing at a very personal level in this. Wonderful. So just one comment I had about wire going from first metacarpal into second metacarpal. As a part of the CMC tightrope assembly that we use nowadays in place of a conventional tendon graft that is used for LRTI, it involves passing a wire from the first metacarpal into second metacarpal in a closed fashion without any opening of that area. And fortunately, we have been able to do that with uncanny ease with very less number of attempts. The trick being the first metacarpal has to be engaged at 90 degrees to its axis, parallel to its joint surface, aiming at the second metacarpal to engage at least at 45 degrees. The difficulty is in engaging the cortex at 45 degrees and not really aiming at the cartilage. Aiming at the metacarpal. Aiming at the bone is not a problem. Engaging the cortex at 45 degrees is slightly a challenge.
All right. I think that should be good enough. Amit, thank you very much for an excellent presentation.
Thank you very much.
Go on to the next one, Samrat. Professor Dr. Samrat Tauri, please.
Thank you, sir. And thank you, MOA, Dr. Vaidyankar, sir. We start with acknowledgement and thank all my teachers, those who are in the stream and others also, who have made it clear that hand therapy is as important as doing a good hand surgery. So this 30-year-old male laborer, he was working on an ARA machine. He had an injury. This is injuring the thumb and the second metacarpal region dorsum. He was otherwise healthy and non-smoker, but he was deaf and dumb. Parents about the age of 6. So that was after debridement, and there was loss of metacarpal shaft region. There was comminution at the base region here. So this is a different fragment. This is a different fragment. There is also one. This is another different fragment, and then the base, and this is a small fragment here. Index sorry, the extensor of the thumb was partially cut, and this is like a unicortical fracture of the metacarpal of the thumb. The same X-ray. So contamination was taken care of. There was skin loss, but then the things were done in a dorsiflexion of the wrist. So skin loss was managed with a rotational sort of flap. There was index metacarpal loss. How to manage that was a question, and a thumb extensor that was partial injury. So what I did first was that I transfixed the second and the third metacarpal to maintain the length, and planned for a bone graft in a second stage. Some literature review here. So we have literature review where free fibular flap has been used. Free fibular flap with silicone arthroplasty has been used for loss of the metacarpal and maybe a joint. And then there is a free non-muscularized fibular graft has been used for reconstruction of the metacarpal in this particular case with very good results for a metacarpal unicameral bone cyst. This case, what they did was that after a debridement, like in my case, they first transfixed it, and after after the next day, they went inside and used an electra for reconstruction and put the plate. So these were like the thoughts in my mind at that time. And then olecranon autograft, this is another case report where they have, in the first case, did the debridement, transfixed it, something like what I tried to do, and then use these to maintain the length. Then second to third day, they went back inside, used a olecranon stud graft, and fixed it with plate. I am not able to do this anytime in my cases. Anyways, so these are the again the images from the article where they have shown that the olecranon osteotomy site heals well after an year. This image is after an year. So I used a fibular graft, and this is how I fix it with fibular stud graft. Though they were flimsy. Sorry. Though they were flimsy, this one was good enough to give strut feeling. So this particular K wire is going through the second metacarpal, then through the graft, and then through the third metacarpal. This healed well, and yes. So while this was on, this is done after 3 weeks of the initial injury, and the patient was the extensor tendon were repaired, and passive extension and active flexion was started right away after the first surgery, and he continued with it. This is after 3 weeks we did the surgery, and this therapy similarly passive extension and active flexion was started, and then further gentle mobilization was started after 6 weeks after removal of the slab. This is at the end of about 6 weeks, and the K-wires were removed. There was good bone healing, and yes, the patient had, in spite of all this, had severe stiffness. He had all these web spaces were completely stuck together. I mean, the fingers were stuck together. There was a decrease in the web space commissure region. So this is what he did. But I had asked him to use cloth, but he used to put these pebbles here. And he came every third day. He was very poor. Wife is handicapped, and but he used to come every third day. Then he used to come every week, and that he continued for a pretty long time. That is a rotational flap incision which I had taken. Before I proceed, I want to tell you that I had offered him a fibular graft for this, but he was not ready because he had seen his wife, who was a bit scared about handicap. He was not ready for electrous graft as well. That's why I had to use the olecranon graft. He went back to work after 5 months of injury. He went back to work at the RM machine with the same capacity, And but more to functional range of motion of the metacarpal phalangeal joint in one paper is 19 degree to 71 degree. In another paper, it has to be the extensor lag should be less than 30 degree. The extensor lag should be less than 30 degree, and the flexion should be more than 70 degree. So that was something interesting I found. That is after 9 months of post injury, and he has no pain. He is able to carry out all his pre-injury work. Though we can understand that his range of motion is less than, his extensor lag is about 45 degree. He also has got a flexion deformity at the PIP joint, and his flexion is almost complete. As for the DASH score, he has done well. Thank you.
Okay.
That's one case. Yes.
Sorry, please, Samrat, go ahead.
Yes, sir. That is it, sir.
You're finished, Samrat?
Yes, sir.
Dr. Bhatia, you want to say something how you would have managed it differently? Dr. Hemant? Dr. Hire, please. Mute. You're muted, Pankaj.
Samrat, congratulations. I think there are a lot of take-home points from the long case that you presented. One, very thorough debridement. So congratulations. I think you did an excellent job. A primary cover. And 3, immediate thought for a good skeletal reconstruction. I think these are extremely important points. Something which I noted through your case presentation was, I think we should make an active attempt to ensure that the MCP joints remain flexed all through our treatment. If you would notice in almost all of your pictures, the focus is so much on the metacarpal that the metacarpal phalangeal joints perhaps remain in extension, and then you have to deal with them sooner or later. That's one thing. And though you have achieved very well in this, see, even in this picture, your plaster cast is holding the metacarpophalangeal joints in extension, perhaps. I may be wrong.
Sir, extensor tendon were repaired.
Extensor tendon for the index finger was repaired.
Yes, sir. So I had kept the MCP at about 70 degree, and PIP joint and DIP joint were mobilized.
Okay, fine.
So sorry.
So yeah.
Slab was still here. Was still here.
Yeah. So sometimes that is a challenge whenever we are dealing with a composite loss. Sometimes the nerve and the tendon injury will dictate your final position of immobilization at the cost of the stiffness of the joints. Though it did not happen in these cases, for listeners, I would just point out one finger that in many crush injuries, the casualty is, irrespective of where the injury lies, the casualty is the first web space. So no matter where else we are working, dorsum or index finger, little finger, tendon, nerve injury, a particular attention has to be paid to the first web space so that it is held nicely open. If you need to hold it open using a K-wire or a small fixator, so be it. But we cannot have everything else healed and then have a first web contracted. So these are the points which I would take from your case. I think wonderful thing. And I would not remove a K-wire at 6 weeks when I put a segmental bone graft like that. I would leave it in place until I see a solid union.
Yes.
But wonderful case. Thank you very much for presenting this.
No, I have no words to say. It's a wonderful case.
Yes.
Wonderfully managed.
Dr. Bhatia? Okay, but Dr. Bhatia is not there, then I think, yes, as everybody, all the panelists have mentioned, it was a wonderful presentation. This should be the bottom line for all people who are listening, that antibiotic is not the first line of getting over the contamination. It is the debridement. If you think it's a antibiotic, then you are heading for big trouble. The second thing is rotation of the flap. He has used a flap to cover the wound. It was not strangulating sutures. You can't close the wound with 4-0. You use 3-0, 2-0, 1-0, and then you are ending for more disasters. So these are the few highlights which Samrat has nicely shown and has been seconded by all the panelists here. I think if any question is not there,
yes, sir. I have a question, sir. I have a question.
Samrat, sorry, louder. Sorry, I didn't hear.
Sir, what is your method of keeping this metacarpal distracted? This construct is very difficult. It just slips off. This construct is very difficult. How to keep the metacarpal distracted if you are doing a two-stage surgery? In my case, I could put a wire, but when the fragment is very small like this wire may not hold. Then how to keep the metacarpal distracted? What do you do, or like what can be done?
Yeah, if there are bone PCH which warrant distraction, if there is a good chunk of piece, it will take a 1.2, 1.5 mm K wire, and if the bone piece is so small that it won't even take that wire, then you have to go to the next logical station, which is the proximal phalanx. I have used this type of wires that you have shown with a bend. Yes, it rotates, but it's meant to be temporary until you come back with something else. The two wires that you had put from one metacarpal into another, they were very close. I felt I would at least put them a centimeter apart, as the bone would allow. Yeah, this is too close to each other. Obviously, when you did the fixation, you added one more K wire distally, which was the right thing to do. It is the same external fixator principle. One wire as close to the fracture as possible, the second wire as away from the fracture as possible. Just one more point about the olecranon bone graft. If you take the graft from the ridge, be careful. I have had one patient who fractured his olecranon after I took a graft from there. If you are taking the ridge, if you are taking it from next to the ridge, from the soft bone, it is fine. But when you are taking a cortical sliver like you mentioned, just be a little careful.
Hemant?
No, I do a lot of olecranon bone grafts. I have not had this problem. I'll pay attention to that. But I like to take the ridge. In fact, the ridge gives me a very good, I would say, a strong cortical bone.
Yeah, only after
I go purposely for the ridge.
Yeah, I've learned that grafting technique from you, but then I just thought
I have not had, and I don't pay particular attention to the elbow. I think I should keep it in mind. I've had a few fractures of the distal radius bone graft area, but not this.
Yeah.
So far.
So, sir, what is your technique? Do you put first you put K wires to mark the bone graft, and then use then you use an osteotome, or you directly use osteotome?
Pardon?
How do you take the olecranon bone graft from the ridge?
I take it with a sharp osteotome directly, probably because I'm getting slightly impatient. But if you want, you can make multiple drill holes with a rectangular bone graft with multiple drill holes of 1 to 1.5 millimeters, and just join all of them. You will not have a fracture of the olecranon definitely while taking the bone graft. You may have it later on as a result of some weakness, inherent weakness in the cortical integrity, but I have not had that experience so far. It is one of my most favored bone graftings, olecranon bone graft.
I think my job is done. I hand over back to Dr. Vahagaonkar, please. Thank you, Samrat.
Thank you, sir. Thank you so much.
Thank you everyone, and I think that was a fantastic discussion. I think we have a few more minutes if there is any additional case that anyone wants to present, or Dr. Jindal sir, if you would like to share. Samrat, you have a case to present?
I have a case, yes sir.
So Jindal sir, can we take that case?
Yeah, sorry, Samrat, you didn't say. I asked before that. Samrat, back to you.
Thank you, sir.
Thank you, sir. This is just a 3-slide case. So this patient had injury of the proximal phalanx, was managed by splint and by strapping. And when he came, I don't have his pre-op video, but he had a flexion deformity about 30 degree, and he had to flex for 10 degrees. So it was a job of moment at the PIP joint, and his DIP joint was also stiff. And that was his X-ray, some rotation, angulation, and definitely he had this subsidence also. So we did an open reduction. This was about 4 months of injury, but we could get to the fracture line and reduce it and put these wires. I did not put any lag screw types, but this was straight wires almost perpendicular to the fracture line. And this is his X-ray after about 4 to 5 weeks after, I'm sorry, about, yes, 5 weeks, I removed these wires, and it was good healing there. So this patient was on continuous follow-up on WhatsApp and on exercises. Whatever he gained, the range of motion was over a long time with lot of exercises and the rubber band type of splint, which we use for the PIP joint flexion, the terminal flexion, and then we got this result. Thank you for giving me opportunity to speak on 2 cases.
Hemant, comments? No.
Excellent.
Pankaj?
Only thing is, I would not use, I would use screws, AO screws, 1.3 millimeters. Probably wires would hurt the extensor tendon, but the result is phenomenal.
Pankaj?
Definitely,
Yeah,
I would use screws in this.
Yeah, I think the most important decision was to do a good open reduction. And as I would use screws, and in open, the trick for good open reduction and good results in such cases is Samrat, if you can go back to the X-ray previous. Your exposure of the fracture should be right up to both the spikes that you are seeing in your lateral X-ray.
Yes, sir.
Those, unless you expose both those spikes completely, getting a good reduction is difficult. That's the only comment I would make.
Right.
Yeah.
Pankaj, you'll put a plate or put an external fixator?
No, I would put screws. I'm quite agreeable to putting wires, but personally, I would prefer to put screws.
Any plate there?
No.
I'm coming, Hemant. I'm coming. Pankaj, is any plate there?
I would not, because this fracture is a long oblique fracture, will allow me to put 3 interfragmentary screws. So no neutralization device is required for this.
Okay. Any external fixator there?
I would not.
Yeah. Hemant.
No, only interflex screws. No plate, no external fixator.
Dr. Bhatia is there?
Yeah, I agree with what you're saying. Perhaps close reduction could have been achieved. It is a fresh fracture, but open reduction is the way to go, and interfragmentary fixation by the method, whichever one is more familiar with. And what is more important is to do it under local anesthetic so that the rotation can be controlled. Because the patient has to be asked to flex and extend the finger intra-op. When we are dealing with a long spiral fracture, the risk of even 2 degrees of malrotation would lead to the finger crossing the adjacent one.
Fine. So we have consensus here that the patient did require open reduction. We have to watch for scissoring. We have to watch for acute reduction. and early mobilization, as Samrat has rightly shown in his follow-up here. Anything else you want to add, Samrat, here? In this case, yeah, Samrat, please go ahead.
I have assisted Dr. Patankar in one of the cases where he would go volar to release these adhesions with a flexor tendon here. So I wanted to ask when do we do it? When do we go volar? When we are seeing a spike here, when do you decide when to go volar here? Another question, technically, beyond this, the central slip is getting attached here. So how comfortable you are to dissect the extensor tendon till here? Because when for reaching here, as Iris has said, if I have to dissect more than beyond this, I have to actually incise the extensor slip here also. And thirdly, I have assisted someone who actually goes by the lateral approach. He does not take a straight extensor tendon splitting approach. He takes a lateral approach between the lateral band and the tendon. So 3 questions about the approach.
Hemant?
Yeah, the last question first. I'm quite uncomfortable with the lateral approach. I would like to see both sides of the bone and probably some part of the front of the bone to know exact that I'm getting the exact reduction. And that's why I never take a lateral approach in this case. I always take a dorsal extensor splitting approach. Regarding this flexor tendons, actually this is a level of the fracture is beyond the mid shaft of the proximal phalanx. And here the incidence of fracture tendon, I would say adhesions or injury is quite less, though one must keep it in mind that while examining the patient, if you find that the sublimis and profundus tendon are working and there are no, and passively you can extend the finger, then I think there is no need to worry about the flexor tendons in this case. You need to worry about the flexor tendons, especially if the fracture is on the proximal half of the proximal phalanx. Proximal third, proximal quarter of the proximal phalanx, then definitely there will be a narrowing of the A2 pulley, and you will have to keep the flexor tendons in mind when you're fixing the fractures in those cases.
Okay.
Can I butt in?
Yes, but Dr. Anil, please.
If at all the flexor tendon does get tethered in such fractures, it is usually at the spike of at the distal end, close to the PIP joint, and not at the other way around. The spike of the distal fragment, which our friend was pointing out, is not the one which will tether the flexor tendon. Usually, when these patients present late, the flexor tendon is adherent at the tip of the spike of the proximal fragment, which is close to the PIP joint.
Okay. Dr. Aire, you want to say something?
Yeah, not really. As far as the approach is concerned, I'm more comfortable splitting the extensor tendon. I'm quite all right to split the extensor tendon right up to the PIP joint, because any tendon attachment is not a linear attachment, or is not a point of attachment. It is something which is spread over an area. So I don't think you should really be worried about splitting it over the PIP joint capsule as well.
All right. Anything else, Samrat? You want to add something?
No, sir. Thank you.
Okay.
Sir, I'm sorry to interrupt, but we still have Dr. Ashok Ghorke with his presentation.
What presentation, sir?
Ashok Ghorke from Navi Mumbai.
Okay.
Still has his presentation.
Ashok, please. Ashok is professor at MGM Hospital, New Mumbai.
Ashok sir, can you please share your screen?
Ashok is...
he was online.
He's not online at the moment.
I'll just call him.
So meanwhile, why do you call him? Dr. Bhatia briefly mentioned about close reduction, attempting close reduction. So the patient that, the case that Dr. Samrat presented. So even if I were to see this patient on day 1, fresh fracture, and I would still go ahead with open reduction and screw fixation because this is an inherently unstable fracture. Yes, what Samrat achieved by open reduction and then put a K wire. Yes, if the plan was to put 3 transverse K wires, then perhaps yes, close reduction and 3 transverse K wires would have been okay. I have done that in the past, and nothing against that method.
Never attempt it. It will not give a perfect reduction. Open it.
Okay.
Open it right from the first day.
And no, I agree. I would because it's a long oblique. It's
yeah. You have
spiral fracture.
This is very unstable. This is very unstable.
I agree with the fracture being unstable. The point I was trying to make is that to do it under local anesthetic, because the rotation can be controlled only with active flexion and not passive flexion.
I agree, sir.
Sir, can I ask one question?
Amit, do you want to say something? Amit?
Yeah. Sir, I just wanted to ask Patankar sir some tips to prevent extensor lag once we slit the tendon vertically and then repair. What precautions we should take and how we should do that?
Yeah, in these cases, after fixing, you keep the finger straight with a dorsal gutter splint. You mobilize, ask them to mobilize your, if you put 3 screws, the fixation is very firm and extensor lag will happen because you have split the extensor tendon, and you start mobilizing it from 2 weeks onwards. Keep the finger in a splint in a dorsal gutter splint, maintain it in static extension in the resting time. In the active times, you can ask him to mobilize the flexors, both the FDS and FDP. And at 6 weeks, when you confirm that the fracture is united, at 6 weeks, when you confirm that the fracture is united, give him a Kapner spring. That will gradually, the extensor lag will go away in the duration of 3 months. You have to splint this on your own. Again, as Pankaj Jindal says, no physiotherapist in this hand.
Yes, sir. So do you have any experience of reopening just to just do some extensor lysis like thing?
Cases which have come from elsewhere, not my own cases. I have opened them, but I have done extensor tenolysis, and but they have not been managed in this manner. So there were adhesions, there were the extensor would not just pick up the strength. So I have done extensor tenolysis in these cases.
And how you repair, sir, after slitting the tendon? By continuous suturing or interrupted?
No, by interrupted inverted suture with Prolene.
Okay. Thank you, sir.
Shall we go to Ashok now? Professor Godke, please. Ashok?
Yes. Am I audible?
Yes.
Yeah, good evening. Screen has been shared?
Yeah, go to the first one. You're on second slide.
So this is fracture 5th metacarpal neck, boxer's fracture. And this patient is 36 years old, ENT surgeon. He had a boxer's fracture and he wanted a surgical management. Because what he said is he's a microsurgeon. He uses his ulnar border of the hand for hours, and like he keeps, and then he does his microsurgery. So he was very much keen about that. Clinically, there was 2 millimeter short little finger as compared to the normal side, and slight scissoring was there. And this was the X-ray. So if we see, the angulation was around 80 degrees. And this was the X-ray. So in this case, still can we go for a conservative management? That is the question to be asked.
Okay, Dr. Bhatia, please.
Since the patient is asking for a operative fixation, I would offer surgery. But otherwise, I would be quite happy to conserve these fractures.
How will you fix it, Dr. Bhatia?
Yeah, the axial wires which will hold the head of the metacarpal in the alignment. Putting transfixing wires from the proximal to the distal fragment is not very easy and doesn't hold very well in my experience. So putting flexible wires from the base of the metacarpal works well in my hands. I do it under local anesthetic. It takes about 5 to 10 minutes to do, and I mean, it's not very difficult.
Okay, Dr. Hire, how would you manage it?
Unmute, Dr. Pankaj, please unmute.
I don't agree with the use of the term conservative treatment. I think we should stop using that word. We are talking about whether it's an operative treatment or a non-operative treatment.
I meant non-operative.
Yeah. No, not about you, sir. Yeah, in any case, anybody. I think conservative does not give us the correct information. So whether we are dealing with so this is perfectly amenable to a non-operative treatment also, and with a good close reduction and plastering with under a proper anesthesia, definitely amenable to good close reduction. Among all the methods that I have used for internal fixation, or rather operative treatments which I have used, I have been happiest using the intramedullary bouquet wires, and so have been my patients. They have been the happiest. The second choice of treatment which I'm very happy about it is using the fourth metacarpal as an external fixator rod. So I put 2 K wires from the base of the fifth metacarpal into the fourth metacarpal, and 2 K wires from the base of from the neck of the fifth metacarpal into the fourth metacarpal, and the fourth metacarpal itself acts as an external fixator rod. I've been quite happy doing that as well. So these are the 2 operative methods which I'm very happy about. I've fixed these fractures using condylar blade plates also. Nothing against using them, but for the extent of surgery, I don't think the benefit is commensurate. The ease of mobilization is as good with intramedullary bouquet of K wires.
Hemant?
I slightly differ here, Pankaj.
Yes.
I think intermetacarpal wiring is very good if the fracture is very subcapital. This is a fracture of the neck of the metacarpal, and it is perfectly amenable to a flexible antegrade intramedullary nailing. Only thing is, in these cases, one must also remember that if you see the lateral view or this oblique or whatever view it is, you see that there is a sharp spike of the proximal shaft here, and this spike has already hurt the extensor tendon. So these patients are more likely to develop a extensor lag or MP joint stiffness much more than others. If this appearance is seen, then you have to be very careful about the MP joint stiffness, especially when this case patient is of a surgeon, and he will have a lot of morbidity or prolonged, I would say, visits to physiotherapy or for recovery, or it will take long time to recover if this sharp spike has not been attended to. This is a case for close reduction and intramedullary pinning or antegrade intramedullary fixation.
Fine. Dr. Ashok, how you managed it there?
So we undertook this bouquet pinning vouchers technique. So here we use this K wires. Now this K wires, we cut the sharp, the pointed ends, and we turn it around like 90 degrees, and we even give some angulation for all these 3. So this makes the passage or entry very easy, and you can even hammer or other, you can tap on this so that the wires goes intramedullary to the fractures. So this was done. This is a Siam view, Siam pick, and this was a lateral, and this. So we were able to reduce the fracture, if you see, and there is a nice fanning of this, the tip of this intramedullary wires, and this was done. So let's see if I can run this. So this is the video of Siam intraop video. So we can see
we cannot see
fracture line is no.
Dr. Ashok, we cannot see.
You are not able to. Sorry. So I'm sorry I'm not able to run the video, but this was the surgery which was done. So we were able to.
Yeah, I think now we will be able to. I think
Yeah. No, but video is not running, sir.
Okay.
So you got the good full range of motion.
Yeah, we got full range of motion, and basically this case, like he had come in April, and that time this COVID times was on a very high rise over here, and then we were very skeptical: should we operate, should we not, and but he was very much interested to get operated. So this was done, and he's very happy. He's doing all his surgeries
without hitting anybody, right?
Yes.
Okay, how did you immobilize this, or how did you mobilize it post surgery? Anything you want to add to whatever you have said?
So we did put a dorsal slab in functional position for 2 weeks, and once the stitches were removed, we immediately started his mobilization.
Dr. Hire, would you immobilize for 2 weeks after the surgery?
I would simply put him in a cock-up slab and leave the MCP joints free and allow him to start using the MCP joints immediately. Once the wound heals, I would get rid of the slab, say around day 10 or so.
So we did the same. For 2 weeks, we kept the plaster and we removed.
So Hemant, will you immobilize the MP joint after surgery?
Yeah. I'll immobilize it for 2 weeks, MP joints in flexion. Okay. I am this patient, if attention is not paid, he will develop MP joint stiffness because of that spike. So I'll pay attention to that all the time. I'll mobilize his PIP and DIP joint. Another thing I would like to highlight for the audience is that make sure that the wire is cut at the level of the MP joint, at the level of the CMC joint here. Don't cut the wires longer, otherwise they will hurt the extensor tendon and you'll have tendon fraying. You can get away with cutting the wires longer only in the 5th metacarpal. All other metacarpals are unforgiving and you will have extensor tendon ruptures. Cut the wires as close to the metacarpal as possible. For that, you have to insert the wire at least 8 to 10 millimeters away from the CMC joint or distal to the CMC joint, to be precise.
On the base of the metacarpals.
No, at least his diagram has shown that the diagram was quite correct, that the wire is going about 8 to 10 millimeters away from the CMC joint. The first diagram, what is shown. Yeah. Here you can see that the entry point is 8 to 10 millimeters. This is the perfect way it has to be done. If the wires go close to the CMC joint, or the entry point is close to the CMC joint, there are two problems. One is that the fixation is not 3-point fixation, then it becomes a 2-point fixation. And secondly, then we are forced to, or perforce the wire is cut longer. In the 5th metacarpal, nothing will happen except for occasional injury to the dorsal branch of the ulnar nerve. In all other metacarpals, you will have extensor tendon ruptures if the wire is not cut in line with the CMC joint. Please be careful.
He has put in the wire from the base.
All the people.
He has put in the wire passing from the base distally. As against, is it not easy passing the wire from the head into the shaft?
No. Why do you want to screw up the MP joint and why do you want to screw up the extensor tendons?
There's an audience here. That's why I'm saying this point.
Yeah, I know. We don't want to damage the articular cartilage. We don't
tell us that putting the wire from distal proximally will hurt the extensor tendon. That's the answer I wanted from you.
Yes.
Dr. Hire, again the same question. Is it not easy to put the wire from the head proximally?
It is much easier, but maintaining that wire until the fracture union will be a big challenge, and it will hurt the extensor tendons very badly, will not allow MCP joint mobilization. However, I must admit that occasionally when I am putting a bouquet of wires, I do temporarily occasionally put a wire through the MP head across the fracture until I get my first couple of wires in, and then I remove that wire. But I would never use it as a definitive fixation.
Okay, Dr. Bhatia?
Oh, I agree with this method of fixation. This is what I was saying in the first place. Putting a wire from the head of the metacarpal backward is a definite no-no for the reasons that we have already discussed.
Fine. So very important carry-home message. All who are trying to fix the head, passing wire from the head proximally, just be aware the method described by Ashok is the method of choice for fixing as and when you do have to fix these fractures.
May I ask a question, Jindal sir, please?
Sir.
Just a very quick question. Is there any role for a headless compression screw or percutaneous that can be passed retrograde with acute flexion of the MP joint, the JAS maneuver, reducing the fracture and then over a guide wire? Has anyone from the experts done that? Is that a feasible or a viable modality of fixation for these fractures?
If I may ask, I have been asking only, I have not been shown that n number of things where he has put in the wire from the acutely flexed past the intramedullary headless screw across the length of the metacarpals. But I think this is much far superior. Putting a hole into the cartilage is an absolute no-no as far as I am concerned. And if it is my hand and I'm coming to one of you, please remember under anesthesia, please put a wire from the base and not from the head. Pankaj Ahire, please.
Yeah, Abhijit.
Yes, Pankaj.
Very unfair. You stole my comment. We are brothers from the last birth, so he automatically knows what I'm going to speak. So yeah, yes, I have done that, Abhijit, and I loved it. I really loved it. It gives a fantastic fixation. But yes, I think it can be done in select number of patients where there's a good chunk of metacarpal head. The split has obviously been completely ruled out, and I have done it for head of the metacarpal as well as head of the proximal phalanx. And
all the cases were very thought-provoking. So unless and until there is any pressing comment or any thought that you would like to share, I would like to invite Dr. Ajit Shinde sir to please make his concluding remarks for this webinar.
Can I just make one comment? Hello?
Yes, sir, please.
Actually, I missed out the discussion on Dr. Tauri's case because I was talking to somebody else on the phone. I was wondering why he had put a K-wire across the IP joint of the thumb.
That was a different finger.
No. In the saw injury to the hand, where he reconstructed the base of the second metacarpal, Dr. Tauri, he had put a K-wire across the IP joint of the thumb. Now, the extensor pollicis longus was cut. I understand that from the description of the wound. But I was wondering why he put the K-wire across the IP joint of the thumb at all, because the distal thumb was not injured at all. I was wondering, I mean, was there any explanation given during the discussion? I mean, I missed that discussion. I was off the microphone at that time.
To bring up that question, sir. That was for the EPL only, sir. Because
no, I was wondering why. I mean, you put a plaster as well. So then what was the need for putting the K-wire across the IP joint of the thumb? Because in the final result, your thumb was stiff in extension.
Okay. Sir, we cannot rely on any of these patients by just using a plaster. And I could not give him a complete plaster. It was a slab. So at the same time, yes, it was for the EPL repair. I had done that, sir.
Okay, right.
Shinde sir, would you please conclude the webinar?
Thank you. It was a very thoughtful discussion which has happened just now based on wonderfully presented hand fracture cases. I would like to thank the panel of experts for sharing their knowledge and wisdom with us regarding this much needed topic of hand injuries. I sincerely appreciate the effort made to upgrade the general orthopedicians, especially from periphery. And not to forget a big thanks to Dr. Ashok Sham for nice arrangement and cooperation. Thank you.
Thank you.
I just have thank you very much, sir. Just one very quick mention about the last webinar, which is scheduled on the 6th of December, the following Sunday. And it's a very interesting topic that we are going to cover, and that is office hand surgery. So daycare, I mean, something that we do in the clinic, such as carpal tunnel injections, treatment of tennis elbow, and so on and so forth. So I really encourage our esteemed members and our team to please come forward with your cases, share your experience with us, and generate a healthy discussion from our team of experts on the webinar. And again, I would like to acknowledge and thank all the experts, our moderator, Dr. Jindal sir, for steering this webinar, our experts for their wonderful insights, and to all the presenters for finding the time on a Sunday evening. Dr. Shinde sir, thank you once again for allowing me to shoulder the responsibility of organizing these webinars. We will conclude next week with the last webinar.